Hello, I'm Julien Edeline. I'm a medical oncologist in Rennes, France, and I will discuss now the role of SIRT or radioembolization for intrahepatic cholangiocarcinoma. Just as a background, we know that the standard of care of advanced intrahepatic cholangio, such as all biliary tract cancer, is standard of care systemic chemotherapy with a standard cisplatin gemcitabine combination. We know the results in all comers advanced BTC to be somewhat in the median overall survival of 1 year. But we need, when we discuss the role of local regional treatment for liver-only intrahepatic cholangiocarcinoma, be aware that results with systemic chemotherapy only might be better in this subgroup of patients with a median overall survival of around 16 months. What is the current role or SIRT for intrahepatic cholangiocarcinoma? We had multiple publications now, mostly based on retrospective analysis, many series, frequently single center, sometimes multi-center. However, this literature is difficult to analyze because it included very heterogeneous populations with patients treated in early disease with first line versus patients treated after chemotherapy in later lines of treatment. The extent of the disease is also very variable between series. Also, we had some series treated with concomitant systemic chemotherapy or patient refractory to systemic chemotherapy. As expected, this heterogeneity results in heterogeneous results with response rates between 0 to 36% and a wide range achieved as median overall survival. Just to focus on two recent series, with a number of patients, around 100 patients. A first series with a median overall survival of around 11 months, which is difficult to interpret whether patients are treated in first line or later lines. For patients treated in later lines, results seems somewhat better. However, this other series did not find any significant difference between first line or later. Clearly, we need to add prospective data to better define the role of SIRT. What have we learned with this retrospective series? One important point, I think, is that we do see in some series downstaging to surgery. Patients treated with large, unresectable, frequently unifocal intrahepatic cholangiocarcinoma that can be downstage with SIRT after and be resected. We just to present one such case with a large intrahepatic cholangio in the middle of the liver, with close contact to the contralateral vessel, which made it unresectable up front. We treat this patient with a combination of SIRT with chemotherapy. And in this patient, we achieve not a major response, but a significant margin appeared with contralateral vessel that enable us to propose the patient for an extended hepatectomy. A year later, he developed a unifocal recurrence, which was treated with radiofrequency ablation. And now, more than 5 years after surgery, the patient is still alive without evolutive disease. And that's an important point, that such local regional treatment can bring a patient back into curative intent in selected cases, of course. We were asking whether this patient downsized to resection could have good outcome following surgery. And thus, we studied our patients, whether they were resected up front, whether they were resected in yellow after downsizing chemotherapy, or resecting after this downsizing SIRT. And quite interesting is to see that results of this patient are indeed quite good, which must put the question whether when we achieve an adequate response with SIRT, to ask back the surgeon whether a resection is possible to achieve long-term survival. We then went on to provide prospective evidence of the role of SIRT, and we designed the phase 2 MISPHEC trial. This is a multicentric phase 2 study. We included 41 patients in 7 French centers. We included patients as a first-line advanced unresectable liver-only population and treated with a concomitant strategy with systemic chemo, with the usual systemic regimen, with the addition of SIRT during the chemotherapy. Our main objective was to improve the response rates, and indeed this trial achieved its primary endpoint with a 39% response rate. Very interesting also is the disease control rate, with a vast majority of patients without radiologic progression. Also interesting are the secondary endpoint, with a median progression-free survival of 14 months and median overall survival of 22 months. As I said, we achieve downsizing to resection in a significant proportion of the patient, and this is important to keep in mind. As regard to toxicity, we did experience some toxicity, mainly hematological toxicity, certainly due to chemotherapy, possibly favored also by SIRT. Overall, the toxicity was acceptable. However, in cirrhotic patients, we do see a frequent occurrence of hepatic failure, which were in many cases reversible, but in some cases non-reversible. And we do think that this combination treatment of SIRT and chemo is not feasible in cirrhotic patients. As a conclusion about this phase 2 MISPHEC study, we demonstrated that SIRT and gemcitabine cisplatin chemotherapy was feasible as first-line treatment of liver-only advanced cholangiocarcinoma. Response rates and disease control rate were encouraging. A high proportion of patients can be downsized to surgery, with a potential for curative in this group. Promising median progression-free survival and overall survival. However, all this data needs to be confirmed in randomized trial versus systemic chemotherapy alone. Currently, some guidelines includes local regional therapy as an option for liver-only intrahepatic cholangiocarcinoma. As I said, we need to think as a potential for a curative resection in the patient for which we achieve good response with this kind of therapy. Ongoing prospective studies are important to better define the role of SIRT and other local regional treatment for intrahepatic cholangiocarcinoma. The SIRCA trial is a phase 3 trial that compared systemic chemotherapy alone versus a combination of SIRT with systemic chemotherapy. However, the trial was closed early due to slow accrual, but with nearly 100 patients included, it might still had important information. Data from a comparison between SIRT and chemoembolization might also give important information. As a conclusion for the role of SIRT for intrahepatic cholangiocarcinoma, we have now multiple retrospective series supportive of activity and safety of this treatment. Few prospective data recently confirm the result, but questions still are not clearly understood. First of all, the comparison with other locoregional therapies, and more importantly, whether this treatment can have superiority over systemic chemotherapy alone. SIRT is included in some guidelines. My personal feeling about the ideal population is a patient with good performance status, lower tumor burden, probably in first line rather in later line. And if we use in first line, we need to add systemic concomitant chemotherapy. Importantly, I think it's SIRT as well as other locoregional treatment are an important tool in borderline resectable cases to give some chance of curative intent treatment. I would like to thank you for your attention, and I'm happy to discuss this in the discussion section. Thank you very much.